One to sign. Okay, thank you. Tia, would you want everyone to sign in the chat so you know who's present?
Sure.
All right, if you get a chance in the course of the next few minutes, just sign in there so we can print that out and record who's in attendance. All right. Before we get started, let me make sure Jess and Amanda are ready to rock if we get going. Okay, good. All right. I'd like to call the meeting to order of the Governor's Council. And as was communicated to you, the transcript of the last meeting is being recorded, or this is being recorded. The last one was recorded and is on file. I don't know if it's at the Secretary of State, but some publicly accessible place. So we'd like to get started to this morning. We have a presentation and discussion area, then we'll go through committee reports and department updates. So why don't we start with, I don't know if anybody wants to introduce Amanda and Jesse, give a brief outline and context to that, or should I just turn it over to Amanda and Jesse?
Richard, if I could.
Yes, go ahead.
So as part of the block grant, both block grants, both the mental health and the substance use, we're required to do a needs assessment every 2 years. And for the last couple of years, we've been partnering with URI and their students to produce that needs assessment. So we have two of those students here today, Amanda Roy, who is a doctoral student at the University of Rhode Island, and Jesse Sullivan, who is an undergraduate, who are going to present those results. So Amanda and Jesse, are you okay with the slides?
Yep.
Okay.
Go ahead and
take it away.
Before we get started, Amanda, would you want people to ask questions while you're presenting? Wait till the end. It's your show, so I want to make sure that we respect that. But
if we could wait until the end, that would be really great because we are tight on time. I've got it down to 20 minutes, but if we start asking questions in the middle, it might start running away from me.
Well, especially if the questions are going to be something you're going to cover.
Yeah.
All right, why don't we try to respect that? And obviously, if there's something very pressing, because there's a great concern, we'll interrupt you and ask the question. Otherwise, we'll try to hold them off. Okay, let me turn it over to you, Amanda and Jesse.
Okay, so thank you for being here with us today. And Jesse and I, as Candace mentioned, are going to be presenting on the needs assessment that we did for the block grant. So we are going to review the block grant requirements for the community mental health services and substance use prevention treatment, including the block grant needs assessment requirements. And we will discuss the fiscal year 2022-2023 application, and then we will examine the lessons learned that we learned from this cycle and how that will relate to our next application, which will be going in September 1st. So in Rhode Island, we utilize a combined application process for the community mental health services and substance abuse prevention treatment block grants. And the purpose of the substance abuse prevention treatment block grant provides a continuum of prevention, early intervention, treatment, and recovery services for substance use disorders and works to ensure treatment services for uninsured, underinsured, and undocumented Rhode Islanders. While the purpose of the community mental health services block grant provides an array of services for individuals with serious mental illness, serves youth and young adults experiencing first episode psychosis, and serves children with serious and emotional disturbances. While this does not cover the entire funding breakdown of both grants entirely, there's a minimum 20% of funds spent primarily on substance use prevention, with maintenance of efforts in place for both women's services and substance use services on the substance abuse prevention treatment side, while on the community mental health services side, 10% minimum for both children with emotional disturbances and youth adults with psychosis.
George.
And a 5%.
Say the wings, the bangs.
Sorry to interrupt, but could you please
that's
mute
good.
if you're not speaking?
The joys of
Mhm.
Zoom.
Zoom, yeah.
Thank you, Ryan. Okay, go ahead, Amanda.
And a 5% of funds have also been set aside for crisis response services, which is new this year, as well as a maintenance of effort on mental health services. As part of the application, the state is required to conduct a biennial needs assessment, as Candace mentioned, with a main question as what are the unmet service needs and critical gaps within the current system. To do this work, BHGDH partners with the University of Rhode Island as part of a workforce development service program. This cycle, our process got a late start because of the COVID-19 pandemic. And URI began the process around the same time EOHHS was launching their evidence update. We took a different approach this year to make up for lost time. We reviewed several of the last needs assessments to see if the same themes came up and assessed what changes have been made or still need to be made. We also included questions regarding the COVID-19 pandemic and how that affected the needs for the next application. Jesse, take it away.
Thank you, Amanda. And it's just been such a treat working with you, Candace, and everyone. So thank you all. So like Amanda was saying, we made some changes, and these are our methods. We did the survey published on Qualtrics and was open from mid-December to the end of March of 2021. Potential respondents were contacted through email listservs or by snowball sampling methods. A number of questions varied in length depending on whether they were a provider, consumer, or family member. 5 email addresses have been drawn to win a gift card randomly for completing the survey. These individuals will be contacted this week by VHDDH. Focus group questionnaires consisted of 6 open-ended questions, conducted one in late February and one in early March. First, the aim was to address the gaps identified from the 2018 BGNA and track any changes since then. And the second aim was to identify how COVID impacted service delivery, treatment, and prevention efforts throughout the state. Thank you. So we were really quite happy with how many providers, maybe some of you here, answered. We had 223 providers answer our survey. We only had 28 consumers and 33 members. We'll be talking a lot about the providers in this presentation. And then we had this state staff focus groups and the state level administrators. We did 2 of those with a total of 12 participants. And now the results. Excuse me. So as you can see here, we broke it up by area, and we definitely had more responses come in from a couple parts of the state. And so our distribution was uniform. We still got really good information, however. And you can see the top areas were Providence and Jamestown, Middletown, Newport, Burville, Cumberland in particular stood out. Bless you. Right there with you. Thank you, Amanda. So we really wanted to look at the importance, asking providers the importance of providing mental health services, and as we'll see on the next slide, substance use disorder services by location. And what really stood out is that, as you can see here, jails were at the top of the list, and for mental health services and assisted living facilities. But the difference between almost 5 and 4.5, that range wasn't huge. So we got a lot of providers telling us that providing these services everywhere was really very important. And if we go to the next slide, we'll look at substance use disorder. We see a little bit of variation, but not a lot. Amanda.
I changed the slide.
Oh, and it just, thank you. And then, as you can see here, jails again top the list, and then we have seniors again toward the bottom of the list. But again, not a huge difference in range. All clearly very important, and that stood out. But jails and DV shelters in particular. Thank you, Amanda. So then we asked what the barriers were to receiving mental health services and substance use disorder services. So starting with mental health, we see that transportation is a pretty common theme here, but transportation showed up as one of the greatest barriers, as was stigma and process, people just not knowing how to access these services. Cost is certainly a factor, and a number of other things, but as you can see here, racial and ethnic differences and care that wasn't provided in a trauma responsive way showed up, I think, pretty significantly. The next one, and then here, substance use disorder services, stigma was seen as the greatest barrier, followed not far by transportation and then knowing how to access those services. And then we see the sort of same line of cost, services offered at inconvenient times, racial and ethnic differences, and the trauma responsive way, sort of falling right behind those barriers. Next slide. So then we asked what would be helpful in accessing mental health services. And telemedicine, and during COVID, not surprisingly, was at the top of the list. And what stood out to me a little bit as well was transportation was right there. So despite the fact that people were still staying home, transportation was an issue. And one of the big ones was mobile treatment stood out. People being able to have walk-in appointments, services in languages other than English, bus pass vouchers, appointment reminders, flexible payment, online services, and services for those with hearing or visual impairment round out. But again, that range is still pretty tight there, as you can see. If we look at substance use disorder, we're going to see sort of the same thing here. So transportation services remaining high as helpful to accessing, telemedicine just right behind that, mobile treatment still in the third spot there, and everything else follows almost exact. Substance use disorder. Thank you, Amanda. And then we just wanted to look at the impact on mental health services provision and how much it was. And providers told us that a lack of state funding for programs had a high impact, as was a lack of appropriate or timely reimbursement came back noticeably high. So we wanted to highlight that. Thank you.
Okay. So now we are going to talk about the results of the focus groups. And we are going to cover all but 2 of our major themes. And those last 2 themes are at the end of this presentation for your reference and will also be in the report for you to review. But for the sake of time, we will not be going into them. So thematic analysis was conducted on the 2 focus groups to assess the key strengths and weaknesses of the current state of behavioral health care in Rhode Island. There was 55% thematic agreement rate reached between the 2 focus groups between the 3 coders. Before analysis was run, all of the discrepancies were discussed between the 3 coders and final agreement was reached. And most of our codes were derived from the 2018 block grant needs assessment, with the exception of the COVID-19 code, which was created exclusively for this, and the telehealth and staffing codes, which emerged throughout the first round of analysis. So throughout the focus groups, the COVID-19 code was our most prevalent code, and you see represented throughout the following slides. The funding code was mentioned the second highest, and in the context of the COVID-19 code, funding was discussed both positively and negatively. And specifically in the context of COVID-19, things like the costs for maintaining residential treatment increased, but income drastically decreased due to social distancing. However, things like the COVID grants aided in offsetting these costs and also aided in the transition into telemedicine. But outside of the context of COVID, funding for staff was noted as being subpar. Funding increased trainings like culturally competent services. The differences between short-term and long-term funding was discussed. Fundings for all substances was noted as equally desirable, not just a focus on opiates. And advancements in fundings led to things like reimbursement for peer recovery specialists, which was noted as important. Outreach was highly prevalent within the context of the COVID-19 pandemic, with most quotes mentioning things like the transition into telehealth services, naloxone distribution, and medication assistant treatment efforts thriving during the COVID-19 lockdown, and the impact of overdose and overdose-related deaths on outreach efforts. And not in the context of the pandemic, outreach was discussed by noting the increase in outreach efforts, specific grants, and creative ways to reach clients. It was also noted that there was an uneven distribution of outreach efforts, such as the oversaturation of outreach workers in Providence, there being a need for a better working definition of what outreach is. And it was also noted that we now have better data around overdoses, which is used to inform rapid response efforts, which is a positive in the face of the opioid epidemic. Throughout the focus groups, housing was discussed in the context of the COVID-19 pandemic using quotes with both positive and negative subtext. The increase in the number of shelters like the COVID hotel program, which fostered engagement and services, was also mentioned. Still impacted by, but slightly outside the bounds of COVID, things like the lack of affordable and stable housing, preventing the completion of a treatment plan or family reunification was mentioned. Increase in homelessness was noted. Working with funders like Medicaid to fund homeless stabilization was brought up, and increased collaboration among providers was also discussed. Cultural competency was discussed in the context of things like elderly clients not being able to fully access telehealth services due to limits with technology. Partnership with agencies like Dorcas International that aid in reducing cultural barriers. While there have been great strides in equality, it was still noted that there is a lack of equity within the state. Culturally competent trainings and participants in these trainings coming from diverse backgrounds was discussed. There was a discussion on how to collect data on race, ethnicity, and culture. And the PBS series on opioids in the community presentations in Spanish was also discussed. General facilitators to services and treatment consisted of things like adaptability in the face of the COVID-19 pandemic, such as the implementation of lockboxes for naloxone and telehealth services. The warm handoffs between providers were noted. Having services like the hotel program set up that made service accessibility mutually beneficial. Increased communication between MOUs between funders and providers, and the sharing and dissemination of resources between staff and agencies. The improvement ideas discussed throughout the focus groups consisted of things like starting more assertive community treatment or integrative health home teams, making better use of the technology that we already have in place, better supporting individuals with the digital transition, incentivizing service delivery as a way to increase access to services, increasing crisis intervention training, actually paying workers appropriate rates or livable wages for services, funding mental health and substance use services equally, which gets at parity, making Olmsted a priority and finding outside advocates to take up the mantle, and striving to find a representative workforce while educating staff and providers on racial ethnic inequality. Throughout the focus groups, staffing was discussed in ways like not being able to retain staff, difficulties with hiring staff, and even in the context of having enough funding to be able to afford staff. Things like unclear job roles and responsibilities were also discussed. Things like staff not fulfilling their roles or duties were also mentioned. The different roles that staff can fill and the workforce being strong despite present barriers were also noted as well. The telehealth theme emerged out of the COVID-19 theme and was mentioned both positively and negatively, fairly equally. The praises included some populations actually preferring telemedicine to meeting in person and increased access to services, especially for those who may have been previously harder to reach because of transportation barriers. While the drawbacks consisted of a lack of anonymity, potential issues with technology and Wi-Fi, not being able to use the services because of a lack of tech knowledge or savvy, and different levels of comfort with the use of telehealth for both clients and providers. Throughout the focus groups, the adolescent care theme was discussed regarding the COVID-19 pandemic, especially with regards to youth and the use of telehealth services, outreach and prevention efforts, increased substance use and mental health concerns, and specific services that are covered by the combined block grant for youths, like the triage assessment at Bradley KidsLink. Participants discussed general barriers to services and treatment in the context of the COVID-19 pandemic, systemic barriers like homelessness, services being at capacity or just generally not being accessible, and staff not being able to advocate for clients. Throughout the focus groups, transportation was mentioned in the context of the COVID-19 pandemic, such that there was greater hesitation around the use of public transportation like RIPTA, and other transportation barriers were also discussed as well, such as the clunkiness with the new contract and the lack of available buses. And lastly, participants discussed trauma-informed care within the context of the COVID-19 pandemic, training curriculums such as the crisis intervention team training, and treatment screenings such that screeners doing these screenings actually sought trauma-informed care training to better assist those that they were in contact with. Jesse?
Thank you, Amanda. Excuse me.
Can I interrupt you, Jesse, for one quick second? Marty, I think you had a question I caught fairly late about the various topics that Amanda was covering. Would you want to ask that now?
Just to note, and I may have missed the survey responses, the 5 on the Likert scale, those were survey, right? Not the focus groups. And were those responses provided to them that they then did the Likert scale, or did they say what the problems were and then the Likert scale?
So the scale was provided to them and part of the survey. The focus groups were separate.
Sure. Did they have an open text field to then add any concerns or issues that weren't provided to them in the first place?
They did indeed. We'll include more on that.
Okay, thank you.
Okay, so, thank you, Marty. Jesse, go ahead.
I'm sorry. So the limitations that we faced, the surveys completed by consumers and family members of consumers had low participation. It could not be analyzed in a statistically relevant way. The provider survey responses corresponded with the type of providers who participated. For example, we did notice a lot of individuals working with DOC responded to the survey, and one of the most prevalent responses was that services being provided in jails were a high need. And we were unable to capture client feedback for focus groups, so our view focused on provider feedback and input. Some of the lessons we learned is that consumer and family response rates to the survey were very low. Utilize quarterly town hall meetings for feedback, or work with advocacy organizations such as NAMI, MHA, and CARES. Provide survey responses, gave a little range of priorities within a Likert scale. Change Likert scale to a rank order for priorities, so there's more variation in the future. I think that goes to a little bit what you were asking about, Marty. And then the regular needs assessment process is being manualized. Request that the state epidemiological outcomes work group provide feedback to improve the process. Will be sent to Governor's Council on Behavioral Health for approval and implemented every other year to collect data that is comparable over time.
So the Combined Community Mental Health Services and Substance Abuse Prevention Treatment Block Grant requires this biennial needs assessment. The provider survey suggests that the following infrastructure changes could be beneficial. We increase services in more locations, such as the jails, shelters, schools, and homes. We address barriers related to transportation, stigma, and the cost, time, and knowledge of how to access services. We consider improving access to services by offering telemedicine, transportation assistance, mobile treatment, walk-in appointments, appointment reminders, flexible payment plans, and services for clients who don't speak English, who are deaf or hard of hearing, and or who are visually impaired. The focus groups also emphasize that trends and barriers observed from the 2018 Block Grant Needs Assessment are still prevalent. However, strides are being made within the state, especially in terms of adolescent care, within the context of the COVID-19 related promotion of the Bradley Hospital Kidlings. This is helpful considering one of the main conclusions from the 2018 Block Grant was the identification of major gaps within the adolescent care realm. Lastly, the COVID-19 pandemic had an impact on every facet of this needs assessment, but under the circumstances, adapting to online platforms and telemedicine was adopted quickly and efficiently by providers across the continuum of care. Thank you all so much.
All right, so thank you, Amanda. Thank you, Jesse. That was well done, very quickly, however. So now maybe we have some time for a discussion, and if you could be available in the future, maybe at a future meeting, we could also continue then. So we always try to fit a lot into these Governor's Council meetings. So if you, I don't have a full screen picture of everybody here. Let me see, because if you raise your hand, I probably won't see you. No, probably won't do that. Just put in the chat room if you'd like to, if you'd like to ask a question, but I do see Laurie Marie, so go ahead, Laurie Marie, can ask your first question.
Thank you, Rich. Thank you, Amanda and Jesse, for this wonderful report and your hard work on it. It's a great service to the mental health community. I have a suggestion or a request for the next time we do this report in 2 years. Number one, would it be possible to look at wait lists for things like supportive supervised housing and the full continuum of care? So congregate care, housing, scattered site housing, and also residential treatment, partial hospitalization, inpatient, intensive outpatient, and also outpatient provider wait lists. I don't know if that's doable, but to see where the bottlenecks are, what how short we are. Two, if there'll be any look at Eleanor Slater Hospital and the civil commitment facilities, who really needs to be there versus who can discharge to a lower level and what those lower levels are, and who might be waiting to get into Eleanor Slater Hospital. Three, inmates who will be discharged from jail or prison within maybe a specific time frame, maybe 2 years, 3 years, inmates who have serious persistent mental illness and what their needs will be once they get back into the community. And lastly, and I'm sure you probably had folks in some of your interviews representing homeless individuals with serious persistent mental illness, but just looking at that population more closely to see what would it take for them to not be homeless besides just a home. What kind of housing? Could they do congregate care, scattered site housing, or something more restrictive perhaps? But just looking at those groups. But thank you so much for sharing this with us. I look forward to reading through your report.
Thank you, Lori.
Wrote all of those down, and Candace and us will discuss all of those and see what we can fit into next year. Thank you.
Awesome. Thank you so much.
Are there any other questions?
Rich, sorry, you can't see my hand. I know with all these people.
Yeah, but if the one way to do it for others too, just put in the chat you want to talk, and I've got that open. But go
Oh,
ahead.
right.
Go
Well,
ahead, go ahead, Chris.
I put my question in there, but
Oh.
is anybody able to give a little update on the legislation from Senator Miller that would provide parity? Because obviously that's one of the big barriers.
Rich, I can partially answer that.
Yeah.
Go
I
ahead,
know that the House had a budget briefing a couple of nights ago, and a topic of discussion was all the BH legislation that is hanging out there. A lot of it has passed the Senate and has been stuck in the House. So my assumption would be that probably next week and the week after, stuff will start shaking out, especially telemedicine has been a big one. The rate increases are another one. The Good Samaritan bill is another one. There's like 6 that they're trying to get consensus on the House side so they can go back to the Senate and hopefully consummate a marriage on some of these bills. Because it's funny, because I said to a few of the reps that I've spoken to over the past 48 hours that why is it all the time behavioral health and substance use and mental health stuff always the last thing to go? This is the stuff that we need to go ASAP, especially in the times that we're in right now. And the comeback to me was, well, everything takes time. And I said, well, you're talking to the wrong guy, because I spent 12 years of my life in that building. So I know everything takes time. But my point is, I said, you're passing stuff like solemnization of marriages, and we got people dying of overdoses, and we got people that need to get doctor's appointments. We need to get something on telemedicine ASAP. And, come on, folks, this is, if we're going to do anything, this is the year to do it. So I think I got my point across, so we'll see what happens in the next 2 weeks, but there's really only 3 weeks left in the session. That's number one. And number two, I don't know if you've read the paper, but it doesn't look like they're gonna spend any of that BH money until they come back in the fall. Just gonna try to pass the budget as what they have on their plate now. And everybody's got opinions on the federal funding. You got Rhode Island Foundation is doing a study, the General Assembly is doing a study. Everybody's doing a lot of studying, and hopefully we can get some good stuff coming out of all these studies. Hopefully it doesn't go into the general fund, and it gets to where it needs to be.
All right, thank you, John. Amanda and Jesse, I don't know if you see some of the questions in the chat, but Kathy Calandra was asking a number of questions about the low response rate for certain areas. Is that because there are fewer providers or the lack of response? So I don't know if you have an answer to that. And the other question had to do with considering adding nursing home representation in the future to the focus. So any response to that?
The email for the survey went far and wide. And we obviously offered an incentive for completing. I can only say that it did go far and wide, and it cast a very large net. And what we got back is what we got back. That's all I can speak to that. I'll let Amanda or Candace speak to the other person in question.
We did use provider email listservs to send them out. So if there are lack of providers in certain areas, that would definitely feed into the lack of areas provided. But with the use of snowball sampling, we did kind of hope to combat that as much as possible. But that would absolutely explain some of the lack of representation in some of those areas.
Yeah, and my nursing home comment, probably more for the focus groups. I think there's value in hearing from them that they also have limited resources to get, and they are ending up with patients, especially younger patients, with substance use disorders and behavioral health problems, because there is housing issues that back people up into hospitals, and it has an effect on these people are ending up in nursing homes. So we don't want to leave out them in terms of where the barriers are.
Thank you, Kathy.
Okay.
I just made note of that.
Before I recognize Lisa, I just want to know that Ian Knowles commented in the chat about the lack of consumer and family participation. Obvious problem. I think you've recognized that. So my recommendation is the report actually have something in there about next time you do this to make a specific effort of reaching out to key organizations and promoting that to otherwise it gets lost, and in 2 years, we tend to forget a few things. So that'd be my recommendation. Lisa?
Actually, my comments were directed at what you were just speaking about. I said, because while I can see that there was a lot of hard work done here, the state has already, engaged with a number of contractors to do an assessment of the provider network and how our safety net is, how well it's functioning and what the gaps are. And so I am slightly concerned that that it's much more of a provider health needs assessment as opposed to a community health needs assessment. And so my suggestion would be that perhaps, and even the focus group that was used, and please correct me if I'm wrong, it sounded to me as if the focus group was staff working, I'm not sure, at providers or at BHDDH. And it would seem to me that in a community health needs assessment, that a focus group that represented the community would have been important for the output, the product of the health needs assessment. So that said, I guess the suggestion that I would make is that the providers should be seen as a partner in order to help you reach consumers and families that are in the community, as opposed to being the individuals who the survey is actually directed at. And I just say this from the experience that we have working with the Hospital Association. We're required triennially to perform a community health needs assessment per the ACA. It is not an assessment based on what we perceive needs as. It is our responsibility to execute what the needs are that have been identified by the community and create strategies so that we can do that. So I would just make the suggestion that perhaps the next time when we are, engaging with this community health needs assessment, that perhaps we use this and maybe some other strategies to really get into the community to identify what the community sees the needs as being.
Okay, thank you. Good point, Lisa. We have time for maybe one more question, or
Could I clarify a little bit there?
Go
So
ahead,
when we
Candace.
sent out the survey, there was a consumer survey and a family of consumer survey. It was sent out to all the listservs of anybody who receives services from SUMLIC, from the recovery community. It went out through DCYF, it went out through DOC, it went out through this listserv as well. And we included flyers and we asked for the provider's help to get that consumer response. I think it's COVID, it did not work out quite the way we hoped, but that's why some of the recommendations for next time is the use of quarterly town hall meetings in order to actually have a consumer there, and then to really use our advocacy contracts to get direct access to the consumers, but we can definitely do through the providers as well.
Okay, yeah, you clearly made an effort. It's just that sometimes by the time you find out it's not working the way you want, it's a little too late. So yeah, it's recognized. And I think this also has to be looked at in light of the almost concurrent, although slightly different, needs assessment survey that EOHH just conducted through the Faulkner Group and HMA. So they're not two separate silos. They work together in the slightly different, but nevertheless we need to look at them in a combined fashion rather than just totally separate. So maybe one will help the other. Okay, thank you very much, Amanda. Thank you, Jesse. Thanks all of you for your questions. I know we could spend a little bit more time on this, and maybe we'll have to in the very near future. But I'd like to move on to the next item, which is equally important, that both Ryan and Candace are going to talk about some open discussion about the block grant supplemental funding uses. So we all have our lists, and we can all send them in. Now, Ryan, let me turn it over to you.
Well, thank you, Rich. I appreciate it, and good morning, everybody. I'm excited we can have this discussion today. Many of you know, as a result of the American Rescue Plan Act, ARPA, all states are receiving additional supplemental funding to their block grants, their block grant allocations, through ARPA to run until fiscal year 2025, to essentially help states respond to what we are seeing in the emerging behavioral health challenges of the COVID-19 pandemic rather. And it's, basically what we'd like to do is take a little bit of time in this meeting, come directly to the Governor's Council and ask you for your thoughts on how we should direct that funding. Now, just a couple of caveats to that before we get started. One is that generally speaking, we've been given guidance by the state in the past that we have to be pretty careful about what we do in terms of how concretely we discuss our funding plans before a public request for proposals is issued. That is definitely the preferred route for gathering solicitations and bids, and of course that's something we want to make sure we adhere to rigorously, but we do want to, we have, I believe the state has taken opportunity, the fact that there is a significant amount of federal funding coming through COVID-19 related efforts, and the state recognizes there's some need to get some initial feedback from community members about how that funding should be, how that funding should be used. So what we're doing is we're going to propose that we have this open, structured discussion. We open it up to consider folks' ideas for uses of this funding. You'll note that the meeting is being recorded, so this will be published on the Secretary of State website. So it's maximally transparent. Hopefully, that's one of the concerns we hope to address in the purchasing process. And then the only other caveat I guess I'd add is that, of course, the block grant itself cannot fund, everything. There are actually a good number of restrictions on just federally what it can and cannot fund. Candace may help refine that a little bit for us in just a moment here. But I do want to note that we're working on ways to make sure that we collect feedback on an ongoing basis from everybody about different funding or program ideas that are compliant with our purchasing regulations, and also allow everybody, the community, to continuously share notions of how this funding should be used, so that we can make sure we're doing the most good with it. So that's very important to us. Where we want to make sure that that we remain strong, that we get a lot of community feedback for how we use this funding in the future, to the maximum extent we can. So with that, I'll turn it over to Candace, and then we'll open it up for discussion.
So I was actually just typing in the text box just for everybody's information. So the first supplement was released back in March. And that was one in which we had about 2 weeks to put forward a plan. That plan can be modified. That's not an issue, but that was for March 15th of 2021 to March 14th of 2023. And in that first supplement, there was $7.1 million in substance use funds and $3.1 million in mental health funds that were made available. The second supplement was released about 2 weeks ago, maybe 3 weeks now. That plan is not due to SAMHSA, our funder, until July 2nd, I believe. I'll have to take a look. It's early July. It won't start until September 1st of 2021, and that's going to go through September 30th of 2025. So it's a longer period of time. For that one, we have $6.15 million in substance use funds and $5.3 million in mental health funds. It's a cumulative total, not annual, but just to keep that in mind. For the sake of this discussion, I think it actually might be helpful just to get everybody's ideas on the table, because sometimes some of the ideas can be borderline. And I think what we've been noticing with SAMHSA and their guidance is that they've been a little bit more flexible. So for instance, one of the things they just recently started to allow is the purchasing of fentanyl test strips. So there was additional guidance that was released to allow that because it wasn't originally part of the plan. Same with naloxone. When it first started showing up on the market, it wasn't immediately allowed by the block grant. Basically, there's been a lot of need and there was a lot of advocating for it. And so SAMHSA has started to allow that. So it's helpful just to have the ideas and then compare them to a list. And it might be easier for me to get back with some people on whether or not things are allowable, just because some ideas might be allowable that haven't been before. We've been noticing that more and more. So with that, Ryan, do you want to just open it up?
Yeah, I think let's open it up to everybody. And what I think we'll, if you could, I think when we post the meeting, I don't actually know how this works. So Tia, maybe you can confirm quickly. When we post the meeting, I don't know if it includes the chat record, but I think just to make sure we're maximally transparent here, if everybody could please just speak in the meeting about any ideas you have so that they're recorded here for the record. Just to note again that this will be published on the, as these all of these meetings will be published on the Secretary of State's website. So to ensure that transparency, but yeah, let's open it up to everybody to share their thoughts, and we're going to record them.
Okay, in order to try to have some sort of order to this, if you could raise your hand, just go to the reaction button at the bottom of the screen, and then you'll see a raised hand, and that places you in queue, and I can recognize you so we all get a chance to speak. I just want to make sure before we go down this road that there are also other kinds of funding coming down that that aren't part of this block grant schedule that you just covered, Candace. So if somebody suggests a lot of mobile crisis stuff, it may end up being that that's a separate federal funding stream. So I think getting the ideas out there is important. And maybe it won't fit into necessarily the block grant, but it could be fit into another funding stream. So why don't we start with suggestion? Go ahead, Ron.
Absolutely. No, I was just going to say, Rich, I'm really glad you brought that up. That this is not the only funding that we expect to be dedicated to behavioral health. That there will be other funding in addition to like sort of a pretty significant amount of general funding that's being given to the state by the federal government with comparatively far fewer restrictions on what it can be used. We do hope that some of that will be used to shore up the behavioral health system and help meet what we see are going to be some pretty significant emerging challenges from the COVID-19 pandemic related to behavioral health. Also just of note, because you mentioned mobile crisis, one of the other key things as part of ARPA is that there is going to be an enhanced match for mobile crisis services. Federal government is going to pick up 85% of the total. For the length of the ARPA period, so until federal fiscal year 2025. So that's another really good opportunity that it means that we don't necessarily need the block grant maybe, to cover some of the services because we'll be able to cover them in other ways.
Okay, so in terms of time, I'd like to devote, probably we can't devote much more than 25 minutes to this, maybe save 5 minutes at the end to see if there are any pressing department updates or committee reports, and then kick everything else over maybe to the next meeting, if that's all right. So please raise your hand if you'd like to chime in there, and then I can recognize you. All right, so let me go first then. I know there's a minimum of a 10% set aside for children's services, but that's the minimum. So, I think in working with the DCYF, the whole area of child outreach, access to services and care coordination definitely needs to get addressed because of the tremendous impact that has on higher end services. Families were many adversely affected by COVID because of employment and housing and transportation and all that sort of stuff. So that has to get looked at. I know it's general, it's at a high level, but just being able to focus on that and do more than just the minimum for the next, in either of those parts in terms of the mental health side as well as the addiction side. Is something that I think should get prioritized. So, okay, Laurie Marie, you got our first hand raised. It's all yours.
Oh, thank you, Rich. And thank you so much, Ryan, for the opportunity. I would say if there's a possibility of putting a little bit of money toward a staff person to work on the implementation of an Olmsted plan and perhaps some funding to actually put things in place according to a plan. And Eleanor Slater Hospital Civil Commitment Facilities. Thanks, Ryan.
Very good. Okay, thank you, Laurie Marie. Lisa.
Thanks, Rich. Thanks, Ryan, for giving us the opportunity to have input on this. I guess this is kind of an old drum that some of us have been beating, but we've really focused since 2014 on strategies to combat the opioid crisis. And while we've done that, and we had done some really good work early on, and we know that the pandemic, really it kind of took it to us, and we have some more work to do. But while we're doing it, is there any opportunity that we might be able to address some of the alcohol use disorder issues that we are facing? Because I can tell you that from the perspective of where we sit, our EDs certainly are seeing an increase in the number of individuals who are coming in who are struggling with that dependency. And we knew that had never gone away, that it had continued to be the #1 abused drug, generally speaking. So if there's any way that we would be able to direct some strategies towards alcohol, it could be very beneficial to the community.
Okay, great, Lisa. Thank you. Great comment. Brina, you're next.
Thank you. Just along the same lines as Lisa was stating, is there opportunity to develop more enhanced program within the emergency departments relative to transitions of care, as well as a better system for identifying and expediting behavioral health needs that present in the ED? I don't think that it's uncommon for someone with a behavioral health issue in an ED to spend 8-9 hours in the ED, and the disposition doesn't, and it's not a criticism, it's just, a byproduct of the system. And then, to really leave there with a plan and follow up that would support their success in the community versus a return to the ED and subsequent inpatient, I think would be, just one way in which we might be able to have an impact on the community.
Good point. Excellent. Anybody else? Okay, Chris.
Thank you, Rich. Thank you, Eric. Once again, I'm thrilled to hear that there's some potential for improving the service system and the access for folks. I know you and I have spoken for a number of months now about the specifically the need for behavioral health care in the skilled nursing facilities. And I think Kathy Calandra spoke to that just a few minutes ago. I just want to make sure that that's on the top of people's lists. As folks know, that system has always been not enough, and one of the large providers pulled out in April, and it just is further evidence that that system of care delivering psychiatric med management and counseling to older adults within skilled nursing facilities is just not sustainable the way it is now. I see Rich nodding because I know years ago that was an issue that you worked on a lot at Gateway. The system has just gotten worse, not better. And we know that, I've gotten on my high horse at a number of meetings and spoken firsthand to the trauma that our older adults who are in these facilities have lived through for this past year and a half. As we sort of complain about how our lives were disrupted, these folks they experienced such significant trauma that any behavioral health needs are significantly exacerbated. I'm getting calls from facilities saying that, they've got residents who are expressing suicidality and they're having to send them to the ED, which we all know we don't want. So please help us with that. Thank you.
Thank you, Chris. Great, good point. Okay, the famous Stephanie Culhane, you're next.
Thanks, Rich. So echoing everything that Chris just said, because this has been a passion of ours, working on RIMAC for a while, and mine also, having worked in nursing homes. So echoing everything she just said, but having been working, for a very long time, but particularly in this last year with a lot of the community case managers with seniors, so people 60 plus, would love to see some type of set aside funds for respite dollars for those particular clients that we see that are facing some type of homelessness issue that need some type of temporary respite that can't go to a shelter. So these seniors or medically compromised people that are facing homelessness, coming out of some type of either mental health crisis from an ED or case management, adult protective service crisis, that aren't going to be able to go to a shelter because they have a medical device or they're too old to go to a shelter, but need some type of respite situation, seeing some type of set aside dollars for those people that would enable these case managers to get them to a safe place to be able to case manage them to a more permanent disposition would really be such a help, for so many that I've been working with out in the community. I know Kathy Calandra and I yesterday just heard of a case. It was with a younger client who wasn't 60 and older, but she was very medically compromised. So maybe even not just for people who were older, but medically compromised people and behavioral health clients are really having a hard time finding spots in homeless shelters. So it would be great to have some respite set aside dollars that would really be able to help those clients get really more comprehensive case management in safe spaces.
Okay, thank you very much, Stephanie. Appreciate it. Susan Storti.
Thanks, Rich. So one of the areas of concern that I have been hearing more and more about has to do with the individuals who contracted COVID and as a result have are now experiencing significant medical complications, including 24/7, 365 oxygen requirements. These individuals are returning home, and there is significant impact not only for them emotionally and psychologically, but for their caretakers and other family members. So creating some type of case management, behavioral health support system that could be delivered at home in the community where we might be able to intervene sooner so that these individuals don't end up in a full-blown crisis, I think would be incredibly helpful if possible.
Good suggestion. Very good. Thank you. Kathy Calandra.
Thanks. I was impressed with actually Marty's presentation last month on the community program, but it was for only the, I was sad to hear that it was only for the access for the accountable entities. So maybe there already is funding. I don't know what the, I don't want to take away from Marty. So again, I thought an expansion of that, because when we talk about workforce frustration, you know, the whole impact on our workforce, it results in problems with stigma. And you know, what we hear is that, you know, it's resources. So anyway.
Okay, good. Thank you for bringing that up. Chris Stranad, DCYF.
Rich, thank you. I very much appreciate the promotion of using some of this money to help out with children and families, obviously. I wonder, these are more general comments. I wonder if what we could do to help expand mental health, behavioral health services through schools and the linkages with schools with the larger system, one. Two, it was mentioned earlier of kind of thinking outside the box. I don't know, thinking of kids emerging from COVID and going into the summer and the social isolation for children and families. I don't know if there's any ability to fund supportive rec programs or something that is behaviorally health focused without being your kind of standard behavioral health service, to just kind of expand connections, socializing, all of that within a supportive environment. Thanks, Rich.
Okay. Thank you. Okay. Kathy, you still have your hand raised. Are you okay? Okay. Didn't want to miss anybody. While we're waiting for other possible hands to go up, one area I think we need to throw into the mix is how do we try to promote access to services in underserved communities? And I know Providence has a significant percentage of communities of color and underserved communities, but every community has it. And I don't think, I think every community should be looked at and see how can we, what services and what outreach or what do we do in other areas that will make care and treatment accessible to communities of color, to underserved populations. And you know, the approach may be a little different. There are cultural issues, there are a lot of issues associated with that. But we do know that you know, various communities are greatly impacted by health disparities, much more so than others. COVID pointed that out. And I think it's equally important to make sure that doesn't continue to happen on the behavioral health side. So.
I just quickly want to read in a couple of things that came into the chat box, just in, you know, again, I think this is posted too, but just so we have it. Margaret McDuff wrote, we should fund for BH mobile emergency response. Some should be put aside for BH response assessment done by teams in partnership with police, including children and adolescents, as is done by FSRI and the Providence Center right now. Similarly, Meg Klingham said we should explore whether some funds can be used for statewide rollout of CIT. Not quite the same thing, but I think, you know, pretty related, for police and first responders, and to it's an effective program that has been offered on a limited basis in RI, but needs to be expanded statewide. But yes, certainly just the realm of law enforcement partnership or other kinds of mobile crisis interventions that we may want to also consider here too. I know that many folks have brought those up in the past as well, and it's something the department's very interested in. So I'll just read those in and then you know, open it back up to anybody who wants to say anything.
Thank you, Ryan, for bringing that up. I was not paying much attention to the chat side. I was looking at raised hands. So
no worries at all.
Multitasking is getting more difficult. Okay. Other questions or comments?
Rich, I just had a question I put in the chat, but are the tribes getting their own block grant dollars, or should they be engaged in this process too as a underserved community?
I'm sorry, I missed part of your statement, Margaret. What is it again?
The tribes. the indigenous tribes, are they getting their own dollars or?
They
The
are
federal-
getting some, they are
Mhm.
getting some, but I don't know how adequate it is, and I don't know the obligation. I think block grant could look at that, but I'm not exactly sure. So go ahead,
Block
Ken.
grant we can look at that. It's a federally recognized tribe, so they are going to receive some dollars, but probably not enough, and we absolutely can work with the Narragansett.
Yeah, excellent point, Margaret. Thank you for bringing it up. Yep. I also think that, I mean, everyone, and it got mentioned a few times, looks at, workforce training, but that's always a little bit tricky. A lot of times it's, you send your staff to a 2-hour training, it's one and done, check it off, but it doesn't necessarily translate into improved outcomes or greater access or that. So, I don't know if that is a solution, but I think it has to be on the agenda somewhere, how that can be incorporated into whatever new services are implemented so that the workforce is trained appropriately to provide it.
Rich?
One of the things I think we have to look at, and I'm way out of my comfort zone on this, but it's going to be how this gets rolled out once it's approved. So I know there's a division of purchasing kind of protocol, but in the past, I know exceptions have been made based upon certain designations for certain groups that can move this quickly, because to have everything funneled through a division of purchasing RFP bid process can really extend this out almost a year. And, although we've got some time on the money, we want some of this to hit the street as soon as possible. So even getting some of the awards out later on this calendar year would be a tremendous help. So, but that's not for me to decide that. That's for all you folks who know a lot more than that at the state level to figure out. Somebody was trying to say something, and I think I talked.
Yeah, Richard, this is Kathy Sullivan. I work for Rhode Island Student Assistance, and I'm also a Regional Prevention Director. So I know Sarah Dinklage is not here today, but I would be remiss if I didn't advocate for the continued expansion of student assistance services, Project Success, in every high school and middle school in the state, to make sure it's equitable, that all young people can access a student assistance counselor. So I think that's very important.
Good. Thank you. Good point. Because I think one of the things, and BHDDH would have a better sense of this than I do right now, is those programs you've been funding through the block grant for the last several years. I'm sure you've got some that really get some great outcomes and need to be expanded. So those should be looked at probably for some of this money. Others, there may not be as great of a need, or it may be more of a stretch to improve that performance. And so that's up to you to decide. But something like student assistance or others, it ought to be looked at for, for expansion with this kind of funding.
And then I would also like to say that a lot of the regional prevention coalitions on the regional and municipal level have great connections with local providers, and are doing a lot of work with young people over the summer, helping them with this re-entry into being with each other. And they already have the infrastructure to do that. So if there's an urgency in getting things off the ground, the regional prevention coalitions have the capacity to do that.
Good. Other comments?
I just had one question. I guess it would be for Ryan. Do we know when we're going to hear from the feds on approval for these programs?
Candace will know better than I think it like relatively soon after we submit. They've been fairly quick in these COVID related funds. They've been fairly quick in the turnaround for approvals.
It depends. It usually goes a little bit faster on the mental health side than the substance use, because there's different departments within substance use. So prevention has to review it, then treatment, then it goes to a supervisor level, and then they give us final approval. So for the first supplement, we have approval to start, but we obviously can modify plans, so that's not an issue. But only on the mental health side, we're still awaiting approval on the substance use side.
So you're thinking before summer's end, at least, we would hear?
I think so. I think they also added a little bit of a buffer, and that's because the second supplement in particular starts September 1st, and they're asking for plans July 2nd.
Okay, thank you.
Mm-hmm.
Well, if I think maybe we can move on a little bit to some of the reports, but if anybody in the next day or so has a great idea, I think if you send it to Candace or Ryan, they'd be glad to hear from you on this. So I think this process will go on. I wouldn't wait too long because we have to put things in writing to the feds and get things moving. But it allows us to give it some more thought as we're driving home or in between Zoom meetings these days.
Right. No, and thanks, Richard. So basically, I mean, as soon as you can, and I think what we do with those ideas, if you share them, just to make sure we ensure the maximum transparency, we'll probably post them along with, on the Secretary of State's website. I'll double check that we can do that, but thanks if you want a little more time to chew on it. Absolutely. Thank you.
Good. Okay. Fantastic. So we have some committee updates where we really only have about 15 minutes or so. So if you don't have any information, you can pass on it, and which is okay. But let's start with Lori Marie on the Olmsted Committee. Any updates on that?
Oh, thank you, Rich. We continue to meet with Rhode Island's leaders. Most recently, we met with folks from the Attorney General's office. We met with Secretary Wilma Zeta-Jones. We've met with Senator Louis DePalma, and his feedback was, I'm on board, I'm a champion for this cause, but when I talk to people about Olmsted, nobody knows what it is. So we need to educate people. So I created a PowerPoint and a script, and my group and I have been participating in other groups and councils meetings, agency meetings, giving them a presentation on Olmsted and asking them to endorse the proposal. We continue to collect signatures, and our next meeting is June 15th for anyone who wants to get involved.
Thank you, Lori Marie. Questions? Okay, then we'll move on to prevention. I know Sandra couldn't make this meeting. Is anyone else prepared to fill in on that? Okay, then we'll move on to, go ahead.
This is Shannon Spurlock. Can you hear me?
Yes, I can.
Okay, sorry. I wasn't able to log in with the password, so I'm just on the phone. I apologize. My laptop's being moody. I'm filling in for Sandra and Sarah really quickly to give a prevention update.
Okay.
We had our last prevention advisory committee meeting on March 24th. We had almost 40 people in attendance, so we still have a great group of folks that are participating. We've been very lucky. Our next meeting, just so people know right up front, will be on July 28th from 1 to 3, and that's another Zoom meeting. And our next one will be in September 22nd. We had the pleasure to have an update from RIDE Health Education Framework updates from Rosemary Riley Chamont to let us know that Rhode Island Healthy School Coalition is working on proposing to adopt national health standards that include behavioral health components. So they're working on those drafts right now. We heard similar updates you heard from Candace around the block grant dollars and some new monies that are coming out to provide some additional training and technical assistance for prevention providers. One will be providing support to the evidence-based work group so that prevention providers who are applying for, who are participating in the application to be an evidence-based program. And if they are declined, they can be referred to get some technical assistance to address those deficiencies so they can reapply. And there are going to be some new virtual trainings that are coming up that are specifically related to social emotional health and looking at trauma-informed care and prevention. And so there are several different projects that are coming up that are through the new block grant dollars that should be spent by September 30th of this year. And the Rhode Island Student Assistance has been expanding the number of schools, and in 2021 there'll be 8 new student assistance counselors and then 8 more in the next year after, so 2022. So 8 in 2021 and 8 more in 2022, with the hope that all schools will be able to have a student assistance counselor. Sandra reported at the meeting that the 2 letters that we sent to the governor regarding providing input around adult recreational use of marijuana and looking at the legalization of that in Rhode Island and providing some insights from the prevention field and some information around access to underage access to alcohol during the pandemic. Neither one of those letters have received a response. So she wanted to let people know that that did not happen. So we're hoping to hear some feedback, even just acknowledge that they were received in some way. So it's the second time we've submitted those. So there's a little bit of frustration with the group. In terms of our PrevCon, which is our prevention conference, we have completed our video PrevCon series and started in June planning for the in-person training, which will be happening in January of 2022. We do not have a date or location because of COVID. Nobody's allowing us to choose sites yet. People are still making decisions around what they're doing for larger groups. But I just wanted to let people know that that will be coming, and that will be our second one. So very excited about that. And then we have some additional trainings coming up. We're collaborating with BHDDH, and Candace will be doing a presentation on June 17th regarding allowable costs for prevention providers. And then on June 24th, we're doing a presentation for mandated reporting for prevention providers. And then we still don't have a date, but in July, we'll be doing a presentation on kind of policy 101 for prevention providers. So we have a lot of really interesting opportunities coming up. David Neal did a presentation on the opioid prevention video called Circles and Silence presentation. And I guess it was nominated for 5 New England Television Awards. And everybody who's in the video is from Rhode Island. It's not available right now as just to get it online because it's not designed to be a standalone tool and it needs to have context. But it's interesting just so the group was able to see it and provide some feedback, but that it's a resource that's available. And I think that's it for updates.
Okay, thank you. Any questions?
Thank you. Any questions for me?
Or not? Appreciate it. And we'll move on to.
And Sandra and Sarah apologize for not being available today.
Okay. You're a great representative. I'm filled in admirably.
Okay.
So thank you.
Thanks.
Next, we've got Chris Gadbois for her report on RIEM HAC.
Actually deferring to Janet Spinelli.
Janet, where are you?
Here I am. Hello, everybody. Yeah, we just have a real quick report because we haven't had any meetings since the last, we sent out a few emails. And we are hosting a work group with the Long-Term Care Coordinating Council. So if anybody would like information on that, they could email us. That'll be starting up next week.
Okay. Thank you, Janet. Okay, then let's quickly move on to some department reports. Linda on BHDDH, Linda Barovia.
Good morning.
Good morning.
Nice to be with you. We're very, very excited to welcome Richard Charest as our new director. To my understanding, he started yesterday. A couple of other quick things in the interest of time. Just recognizing and thanking Nina Lennon from the Division of Purchasing for working with us, particularly Corinna Roy, to help find a way to conduct listening sessions to inform the final design of our Cahoots RFP in our pilot. So we're looking really to find ways to provide priority focus on hearing the voices of consumers, families, allies, and advocates so that the RFP can be structured in a way that really is responsive to needs. And so we will be holding a structured, guided listening session in the near future, date to be determined. Also, I don't want to steal thunder from Marty and Jeff Hill, but we've been working with OHHS, the Department of Health, pride, to increase capacity to address a recent spate of suicide attempts by adolescents and children utilizing over-the-counter medications as the means for the attempt. So we've utilized our wonderful network of the regional prevention coordinators and task forces to quickly respond to this effort with sort of a combined summer safety message that includes an adaptation of the Count It, Lock It, Drop It campaign to include over-the-counter medications, and folks have sprung into action very quickly and been incredible at stepping up to the plate. And I think in the interest of time, that those are the most important updates for right now.
Thank you. Any questions or add-ons to Linda's report? Appreciate it. Okay, thank you, Linda. Jeff Hill, Department of Health, and I know you posted something on the chat recently, a few seconds ago, Jeff. Let me turn it over to you.
I did. So we had some carry forward funding from last year, mostly due to staffing costs, savings from COVID, because all my staff disappeared and worked on COVID. And so we worked on some training initiatives. So we're going to be providing trainings this fall on suicide screening. That'll be available through the Bradley Learning Exchange in October and November. One of them is specifically, the November one is specifically for clinicians for the full assessments. And so that's a full day training. Those are gonna be, right now they're scheduled to be in person, so which is kind of exciting. And so I wanted to put the save the date out there for everyone. As soon as that is available for folks to begin signing up, I'll make sure that goes out to the group. So that can be distributed widely and folks can sign up for that. We're paying for it. So, there won't be any cost for folks to attend those trainings other than the fact that you either would not be at work or doing what you would normally be doing during those trainings. So that's the update I have related to that. With relation to what Linda mentioned, I'm gonna have, if I can defer to Marty on that, let me do that.
Okay.
Jeff, on the deferring to me on what?
Just on the work that we're doing, the interagency work we're doing right now.
Okay, perfect. Yes, that's what I was. Rich, whenever you're ready.
Yep, go ahead if we're on that topic. So why don't you go ahead, Marty.
So I think most of you, I imagine, have received information about the behavioral health system review. I hope probably more than once, which is good. That's what we wanted. We had 2 weeks of public comment, which ends tomorrow, with a public meeting in the afternoon to take in comments. So if you don't have that Zoom